up on the phone. Right now, it's just my character.
Yeah, once the game starts. So we are going to start the game right now. Good luck, everyone. Try to apply what we learned yesterday if there is a question related to module 3, okay? Remember, module 1, 2, 3 is your most important modules because that is where the most questions will come from. Good luck, everyone. Let's let the game begin. All right, you got 15 seconds. Pick your best answer. Any answer is better than no answers, okay? All right, I know this is a tough question, okay? Very tough question because we always say lithium is the medication of choice, okay, for mania. But someone could please help me understand why lithium is not the best choice here.
Lithium takes time to start working.
Lithium is for long term.
Short therapeutic level.
So to
The
stabilize them
therapeutic
immediately,
window.
you want to use an antipsychotic.
Yes, because you
therapeutic level.
perfect. So
Also
as
because of the manic episode.
well, lithium is for many episodes, right? But it has a narrow therapeutic window. So what does it mean? That means if I screw up and I give them too much lithium, it can be worse than mania. So lithium takes time to raise the levels. I'm not going to shovel the person's 1800 milligrams of lithium and hope that they get better, right? So what is the therapeutic window, right? Between 0.6 to 1.2, okay? So it's not that, and then what we do is we proceed to transfer the patient to lithium after the patient is no longer manic. So what can we do fast? Well, we could potentially give a antipsychotics, drop the mania down, and then switch to lithium. In practice, myself, I like to do two things. I always do a antipsychotic and do lamotrigine. So I'm covering for the highs, and I'm using lamotrigine for the lows. Okay? Of course, it's not going to be a full-blown dose of antipsychotics. Now, if you want to really, really understand mania, I urge you to read something called Canadian CPG, CPG. It is phenomenal. It will teach you everything about bipolar, like everything that is important, at least. They compare each of the antipsychotics, each of the mood stabilizer in a systemic review, which is the highest level, and they'll tell you which one works the best and how to use and which phase to use, whether it's acute, mania, or depression. So with that tool, even if it is different than what you practice in your hospital, you coming in with a big weapon in your hand. And it's not hard to read, it's actually pretty easy and will make a lot of sense. Once you read the Canadian CPG, you will be a different person, I promise you. Okay? As far as taking care of lithium, just pull up the CPG, be like, oh, I know what to do. Too easy. Okay. So yeah, so using a low dose of antipsychotic like olanzapine in practice, I think it was probably the most used antipsychotic because you can give it fast. You're not going to necessarily leave the patient on it. You could in a small dose if you prefer. I like Geodon or Geodon or quetiapine, Seroquel, right? It's very effective. In fact, the Canadian CPG says it's the most effective. That's probably why I like it. Antipsychotic works fast, right? Faster than the mood stabilizer. And then you could switch to a mood stabilizer. Now, if you don't want to use a antipsychotic, Depakote you can give a lot faster than you can do lithium. And I know this question will be super tricky for those that read the books and don't quite understand beyond of what they are reading, because nobody teaches this. Everybody says lithium is the gold standard. It's the medication of choice for bipolar. Obviously, you read the question. What are you going to pick? Lithium. And that, it is a problem for the board. Okay. All right. Next question. All right. So we said yesterday, although this question was fairly easy, hopefully those that didn't get it right is because they were too fast and they picked the wrong answer, right? But if that's not the case, we can explain it too. Questions that are easy always come with a little bit more challenging topic. Addiction, dependence, abuse, right? Would have been a good combination of that. So if you ever see a topic that is easy on the course, ask yourself, why would that be there? What kind of tricky questions can they create since this topic is so easy? Let me give you a perfect example today. This is actually a very good example. All right, someone emailed me today. It says, Dr. Lopes, you did a very good. Well, let me finish this topic here. What is tolerance? Nothing but needing more of the same substance to achieve the same effect, right? What is kindling? Lowering the threshold, seizure threshold. What we will be concerned for, alcohol, Wellbutrin, or even stimulants. Addiction is doing anything to get the drugs, despite of a diverse consequence, losing marriage, money, housing, whatever it might be. And potency, we talked about two medications, haloperidol, right? High potency, and clomiprazine, low potency. Now let's go back here for a second. This is pretty much what I mentioned. Know what is withdrawal, dependency, and addiction. So back to the question that I had today. Someone emailed and says, Dr. Lopes, you really explained well the topic of the right parietal and that one cannot do the clock drawing test. Now he got the same question and did not have the right parietal. So the answers were cerebrum, cerebellum, Help me out. Cerebrum, cerebellum, and two other answers, right? So what do you guys, go ahead. Miguel, are you there? No.
Parietal lobe.
Parietal lobe. Well,
Well,
so basically, what I'm trying to say is that you learn that is the parietal lobe. What if you don't have it?
Cerebrum.
Cerebrum, yeah. Cerebrum would be the answer in this case, because where is the parietal lobe?
and
Right?
it's cerebrum.
Cerebrum. Now let's give
Cerebrum.
you the same question in a different format that could possibly be on your test. Let's say someone asks, where would you document suicidality? What would be the answer?
Mental status.
Thought content, right? Somebody said thought content. Okay. What if thought content is not there, but is MSC?
MSC.
Then you pick MSC. Okay. So let's give another example that is, these two examples are very high yield, actually. Let me give another example. Can't remember one right now, but I'll think of one real quick that often happens. So sometimes you learn the content and the question is right in front of you, scream at you, and then you have to say, okay, where would be thought content, or is that part of what, right? MSC. So that way you don't see thought content, don't freak out. It definitely could be an MSC. Okay, so like for example, healthcare literacy, right? Well, for an example of literacy would compose of reading and writing, right? So if you're looking for reading and writing, inability to read or write in English, but the answer is not there, then the bigger umbrella would be the answer, right? But that is a very strategic way of asking the same question in disguise. So that's why it's very important when you read something, kind of like, okay, so another one, sorry, that's what I was trying to say. Where is serotonin made? Okay, that is perfect. But where would that be in the brain? Brain stem. So that is the one that I was trying to remember. It came back to me. So yeah. So if you don't see the main answer, think of the brain stem, right? Which also norepinephrine would be there. So, these are things that we have to really think about, because sometimes we study, and we're only looking for the things that we study. But we have to go a bit more sometimes understanding rather than rogue memorizing, okay?
I had a question like that, Dr. Lopez, and the answer should have been amygdala, but I couldn't see the amygdala, and there was a limbic system there.
The limbic system, absolutely. That definitely can be it. Absolutely. So hopefully everybody now is aware of those tricky questions. You know the answer. You studied the content. Sometimes it may not be exactly what you're looking for. If you will read the question, you say amygdala, and you look and it's not there, well, limbic system will do it. Right? All right. Good luck, everyone. Next question. Okay, perfect question. It falls back in the same scenario. Everybody knows would be the ADHD frontal lobe. Well, frontal lobe may not be the question for inattention. What part of the frontal lobe would that be?
Those
Dorsolateral.
Yeah,
Dorsolateral.
It's in the RAS
dorsolateral.
system.
Okay, dorsolateral. Also, it said impulsivity. What part of the frontal lobe would that be?
Frontolateral. Frontolateral.
Orbital.
Orbital frontal.
Orbital lateral. Lateral.
Okay, so let's
Orbital
clarify that.
frontal.
Anterior cingulate cortex is not part of the lobe, right?
is for
Okay,
emotion.
so 1 second, everyone. The anterior cingulate process, it is also responsible for inattention. However, it is not necessarily part of the frontal lobe, right? So if the question is asking about the frontal lobe or ADHD, then orbital frontal would be the impulsivity. If it's talking about someone that has anxiety and or impulsivity in general, anterior cingulate cortex, okay? These are things that we really need to understand so that way we're not losing easy points, okay? Conduct disorder, animal cruelties, lack of remorse. Autism, lack of social interaction, lack of communication. When called by their name, they don't look. The broken mirror neuron, right theory. Remember, ADHD has to be in one or more location, right? Remember, ADHD, 3 types. We need to know what falls under each type. Remember, ADHD, which medication starts at 3 years old and everything else. ADHD, remember, if someone started on a stimulant, I don't care how good the stimulant is for the board and develop tics. I don't care if the person's flying. It's become Superman and the best person ever. Does not matter. You stop the board. I mean, you stop the stimulant, okay? You don't decrease. You don't try something else. In real life, we can do many things. For the board, we're teaching exactly what it is. And if that happens, guanfacine or clonidine. What if you have guanfacine and clonidine? Guanfacine, okay? What else? Remember, stimulant medications can cause potential for abuse. So knowing what those potential for abuse might be helpful, okay? I think that is it for stimulants for now, at least. All right, so let's say we don't know anything about psychiatry at all. Test taking strategy, right? And it says which part of the problem, we have a problem. So something's not working, right? So what it is doing is not working at all or hypoactivation. And then if we think about it is ADHD, is the hippocampus ADHD? Is it the middle part of the ADHD, or is it or is it a normal functioning of the basal ganglion? No, right? So technically, if we have a good, strong test taking strategy, we could have figured out without not knowing anything about psychiatry at all. So I urge you to start looking for the cues of the question, right? Because even if I come in today and I know just that the hippocampus is in a different part, the middle is in a different part, I could immediately pick hypoactivation of the prefrontal cortex. Especially, we just talked about the prefrontal cortex one slide before, and we said inattention, dorsolateral, impulsivity, orbital frontal, which is part of the prefrontal cortex. Okay, so it is totally okay to make mistakes now. Absolutely awesome, because from mistakes is what we learn after. No one was born learning. We all made mistakes, and then from that we grew. I mean, this is how it is, right? It's no magic. And the more mistakes you make now, the better it is. Now, we can't keep making the same mistake several times. That is the only thing, right? So here I went on a little bit to talk about the dorsolateral cortex, right? Dorsolateral of the prefrontal cortex, right? Executive function, helping with attention. So if the prefrontal, which is above, is the bigger portion of the dorsolateral, right, in general, is for attention. If it's not working, it will cause inattention. The anterior cingulate is part of the limbic system. Why do I care? Anxiety and impulsivity, right? Anxiety specifically on older patients and impulsivity. So basal ganglia here, right, is the omotum, right? And the reticular activating ability to focus, fight or flight, and arousal regulation. Remember the circadian rhythm, right? Nine seconds, pick your best answer. 4, 3, 2. Okay. One slide before, I mentioned if someone developed a tic. I didn't know this question was coming up. It's just by luck and accident, right? If someone develops a tic, we are looking for two choices. Guanfacine. What if a guanfacine is not there? Clonidine. Okay. I don't necessarily repeat things for fun. If I'm repeating or kind of being excited about it, probably maybe a little bit important. Okay. Now, during the class, we talked about Vyvanse, right? Remember, Vyvanse is used for binging eating. I'm sorry, is FDA approved for binging eating disorder. It is a stimulant, right? And there's also the preferred stimulants for those that might abuse medication because the way it is digested by the body, it can only be consumed, shouldn't be snored all kinds of craziness. Now, the trap for Vyvanse, don't jump in picking Vyvanse because you think the question says binge eating disorder. And if it says that, then maybe it will be the treatment of a choice. Assess if the patient has binge eating or bulimia would be a better choice. So it really depends on the context, okay? So while stimulants like Vyvanse are effective for ADHD, they can potentially worsen tics, right? Think of guanfacine and clonidine for tics disorders. Okay, now what if that is not one of the choices, right? Specifically, tic disorder no longer associated with the ADHD. Then we're going to look for things like Abilify, sometimes even risperidone, and other antipsychotics that could be given for those that could potentially hurt themselves or they are super agitated, right? So Strattera is also a good choice that is a non-stimulant. However, is not approved for tic disorders. Okay, so if you're looking for specifically non-stimulant, Strattera for ADHD would be a good choice. Which also brings the case that some apps out there are saying that Strattera would be the best choice for someone that develops tics disorder with ADHD. I promise you, if you pick Strattera, it'll be wrong. Somebody's very fast. All right, I can see this is being a very hard choice, okay? Extremely hard choice between the green and the red, right? But education for me and the parents, right? Psychoeducation is important as the first step for ADHD management. The first step, right? It empowers both the child and the parents with knowledge about the condition and available treatment of choice, right? With a solid understanding of ADHD, Mia parents can make informed decision about her care, including potential use of behavior therapy, diet modification, exercise strategy, and so on. But I get it why you picked, totally get it why you picked behavior therapy. But think about this way. If the parents do not know how to, in a sense, control or manage the condition, then everything's going to be up to for the kid to do. That's not going to work with the ADHD. Okay, specifically, um, specifically ODD, right? What we want to do as parent teaching behavior skills, right? And conduct disorder, right? All right, we've got 5 seconds. Pick your best answer and go. Okay, I know. Who's going to send the borderline patient to ECT? Come on, we cannot do that, okay? ECT is very effective. What are the patients we send to ECT?
Anyone with psychosis?
Anyone psychosis? Okay, hold on, let me pull that back.
Schizophrenia.
Okay.
Schizophrenia, bipolar
Major
disorder,
depressive disorder.
psychotic
Treatment-
seizures.
Treatment-resistant
Treatment-resistant
depression.
depression.
Yeah,
Yes,
they said it.
so,
Disease.
in summary, major depressive disorder with psychosis, that it is treatment resistant. That is the key, right? Because even schizophrenia will not send them for ECT unless if we have tried everything else. This is the biggest gun we got. So I know that our borderline may be a little bit out of control, but we cannot send them over here, guys. Okay, not yet. So let's try other things. And there's not a treatment for borderline. Okay, I would have been happier if somebody said antipsychotics rather than ECT. Now let's continue on ECT. What is the number one side effect that I'm concerned about?
Short-term memory.
Okay, so what are the contraindications for ECT?
Cardiac issues, arrhythmias, seizures,
Brain seizure disorder.
head
Perfect.
tumors.
Pacemakers.
All right. All right, folks. So, yeah, so I just want to make sure that you guys are thinking through all this stuff because everything is important. If we think about dialectical behavior therapy, we think of Marshall Lineham. What is the goal of dialectical behavior therapy? To decrease suicidal self-harming behaviors, right? What else about dialectical behavior therapy? Nothing else is more important than that. Okay, so everything that we cover in the course, it is important. It's not there for fun. I promise you this. Okay, if we cover in the course, there is a meaning behind of the intent. All right, so I have a question. So someone asked me today, Dr. Lopes, I had a question on borderline personality disorder. One question, the answer was Depakote. The other one was SSRIs. How and when do I choose each one of them, right? So basically, in the question, well, let's clarify. There is no drugs that is FDA approved for borderline. Okay, so we are aiming to decrease the symptoms. If they present with any type of depression, SSRI. Maybe if there is an aggression, Depakote. Maybe if there is suicidality, lithium. But the safest thing is SSRI. Start with a small gun, and then we start increasing as we go. Okay, but that was a good question too that I got today. So DBT, think of, excuse me, DBT, think of a Marshall Lineham always first, right? Did you guys know she actually had borderline? Well,
Yes, they told us.
yeah, diary keeping. Now, let me clarify that, please, please, please. It is not part of the DSM-5. You do not need to make the diagnosis, but it is super helpful so that they can start putting their feelings and annotating what triggered the event. Okay, so it helps with the diagnose, but it's not part of the DSM-5. Now, let me ask you a question. If you know the answer, for diary keeping, what psychiatric condition would be part of the DSM-5? Say it again?
Journaling.
No. As part of the DSM-5, there is one psychiatric condition that you should keep a journal.
PMDD.
EM. No, say it again?
PM.
PMDD.
Perfect. Okay. Yes. So know that not MDD, PMDD, right? So because they have to keep a diary of what is going on. All right. Very good. So remember about borderline. Remember about emotional uh, object permanency, object constancy, and remember about sensory modem, right? So sensory modem, PAG, do not follow the age. Let's say this borderline patient is 35 years old. Do I care? No.
No.
So what they did not accomplish is the ability to know if the therapist goes away, the girlfriend, the boyfriend. It doesn't mean it is the end most of the time, right? That means they just gotta go work or do something. They'll come back. I don't have to freak out. Okay. So watch out for things like sensory modem, for example. Uh, you know, things that fall under the sensory modem. So it comes back to the same question that we taught today. If you're looking for one answer and you don't see it, what falls under that answer as a group? That is a very important lesson that I probably should emphasize more often. Oh, okay, that was funny. I cannot agree or disagree with that. Okay, I'm not gonna say it. You shut down my website. When I see it tomorrow, go to work, I'll be in jail. What happened to Dr. Lopes? He's gone. All right. All right, so sorry about the misspell there. I didn't have time to go over this. Yeah, so if you think about the narcissistic, and think of this way, you always going to remember the best thing ever since sliced bread. Okay, and they are difficult to work because you cannot criticize or say anything. They take it so offensive.
Yesterday, they closed early.
They take it so offensive, right? So they believe they're the best thing.
Tomorrow, then.
They want the accolades, but they do not want to do the work. That doesn't work
Work.
most of the time,
Mhm.
right? So
Dr. Lopez, I am at work, but I regret it because I know the question, the answer.
there you go.
This is
That,
the man.
good for you for being at work and trying to get the answers right. That's good. So, this extreme sense of importance. Let me tell you something, guys. Everybody's replaceable. I don't care who you are. Everyone is replaceable. There is no so important. Find somebody else that do better and cheaper. That is the truth of the world. Okay. So they will exploit others, right? Not as much as the antisocial. Those are probably the most difficult ones, right? But belongs to the cluster B, and they kind of intersect. They're kind of like brothers and sisters, right? So, all right,
Have you gotten any antisocial patients in your practice?
all the time. That's why they're in jail. I see one every single day. I see the prison population. I do. I mean, honestly, some of them I feel sorry for their mistakes. I try to bring some joy and comfort, but at the end of the day, it's kind of hard to reverse what they have been for the past 30 years, right? So they come to me. They come to me, and I'll keep it that. Odd beliefs. All right, first thing first. Good job, everyone. Very good job. Okay. All right. I was thinking that schizoid was going to be one of the answers. And I was like, I can't believe everybody got it right here, or mostly right. First things first. On the test, you know how I say that we're looking for the most likely diagnosis of the question. They will never give you the full criteria, never, ever, ever, because if they are going to give you five symptoms of a major depressive disorder, plus 2 weeks of time, over 2 weeks, plus rule out of medical condition, plus X, Y, and Z, they're not going to do that. Now, there is something we can pick up from here. Generalized anxiety disorder. They must say 6 months. Okay, what if they don't? Well, if they are referring to COVID time and we are in 2026, it is in disguise. But if we look at generalized anxiety disorder, look for a question that says 6 months. Why would that be? Because if not, it makes it very difficult to say, is this unspecified disorder? Is this unspecified anxiety? Is it specified anxiety? It is agoraphobia. It is phobia. It is so many anxiety disorders kind of falls under anxiety that we can pick. Is it panic attack? So it can be so many, right? But generalized disorder, it is 6 months. So heal on the 6 months. Okay. And of course, watch out for things that are in disguise, right? So if it says COVID time and we're in 2026, we can assume that is over 6 months. Watch out for schizotypal versus schizoid. And obsessive compulsive disorder, watch out for tics. Tics can be a compulsion, so don't fall for Tourette's. Remember, we got to know 4 things about Tourette's in general that we covered yesterday. So that way we can pick up more questions around the topic. Provisional, modem tics, vocal tics, or Tourette's. So if you really take the time to learn what Tourette is, you can figure out 4 other diagnoses. Unusual perceptual experience, right? Discomfort around people because they actually want to hang out, but they feel so odd and awkward that they believe no one likes them. Go ahead, Laurel.
Sorry, it was actually a question for after we're done.
Okay, no worries. So we'll do that. And be careful. Schizotypal and schizoid, it's very different than schizophrenia. Now, let's talk about schizophrenia. It's good that you know brief psychotic break, right, from 1 day to 30 days. And other types of schizophrenia. It can only be schizophrenia after it reaches 6 months of symptoms, right? Before that, can be other subtypes of schizophrenia. So it's good that you guys kind of look a little bit under the skin here as well. Okay, so very good. So your obsessive compulsive disorder, they are generally preoccupied in being so perfect that they will miss the deadline of the paper, right? Or anything else. So think of one of the hoard things, in a sense, a little bit cheap and doesn't want to spend the money, want to hoard and keep it everything for himself, like he's gonna take with him once he goes, right? Enjoy life, guys. Okay? And it is a personality disorder, right? So don't confuse with the OCD. Totally different, right? How do we treat the OCD? The same way we treat major depressive disorder, anxiety disorder, with the exception of higher dose. Don't start your patient on higher dose. Over time, you increase and increase to a higher dose until you achieve the results you're looking for. Now, when we talked about obsessive compulsive personality disorders, they want to be perfect. All right, everything needs to be exactly how it is, otherwise they'll be freaking out, right? Don't worry about being perfect. You know, no one is. Worry about doing your best. That is simple as that. You'll be much happier in life. Okay. Oh, okay. I thought it broke. You guys are so smart, so fast too. All right, we got 5 seconds. Pick your best answer and go. All right, almost 100%. Almost. Good job, fan. Nurse NP, PMH and PMHBC. You are calling it lithium and psyche. Good job, everyone.
Yeah, he is.
All right, so if you're in the podium, your job is not to lose the podium. Everybody else should take them out. Right? That's the name of the game. So remember, autism, right? They love to insist on the sameness, fixed interest, poor eye contact, deficit in communication, not answering when called by their name. Okay? Gold standard, ADOS. They will not give you the full name. I'm warning you now. So what is your job? Know all scales by the acronym, what they means, okay?
Dr. Lopez, are you able to change your answers?
Not now. 1 second, please. All right, when you said, are you able to change your answer? I thought you asked me if I can change my answer. And I said, not now once the game begins. It wasn't you, but you are not either, okay? So yeah, because I see some questions that are not properly spelled. It kind of means, but it's my team that didn't do it's actually my fault for not having the time to correct it. But I wish I could have changed some of my answers that I see there. That's what I meant to say. Not now. I cannot change my answer. Neither I don't think you guys can do. Once you record your answers, done. Okay. So I see why some people pick this, right? It really can be helpful too. But the gold standard is really this. Okay. And I was going to say, I'm so glad no one's going to send those patients to ECT, but maybe one person picked too fast. Hopefully you don't send the autistic person to ECT. And psychodynamics therapy. Now, why would you send them to psychodynamic therapy or psychoanalytics therapy, right? That is reserved for some specific cases where they're able to talk about childhood and trauma and relieving the suppressed memory. They are unaware of what's presenting today. It is part of the problem. Something that they lived in the past, maybe gone from memory. They don't even think anymore about it. And yet they are having difficulties with their spouses and friends. It might be something from the past. That's what, in a nutshell, what's psychodynamic therapy. Now, next week, we are going to start module 4. There is a very good breakdown of the entire module 4 document, where each of the therapies, I give you 3 or 4 things, and that's it. So that means if you cannot remember module 4 because it's kind of large, you should at least look at the document and know those 4 things for each one of those therapies, and will help you immensely. Okay.
And where are the documents that you mentioned?
Under module 4, the first video of module 4.
Thank you.
And that is the same thing that we do for all modules. Under the first video of each module, you have your PDF for that module. Okay.
That was the best way for me to make my study stuff. I listened to your videos as I printed out all the printouts, and I just wrote it over and over again until I went into the patho, and it was such a big help.
It is. I mean, and I tell folks, do that in the beginning when you first join. Take the time, spend the $20 and print that out. It's going to help you so much. If you're looking for it because you saved in a computer because you want to save $20, not worth your time at all, right? Spend the money, print it out. Notes will be organized in one place. When you were looking for, where did I see this? Just go to the PDF and it's right there.
Or when your manager is not around, print it at work.
Can't endorse that, but I see where you're coming from.
Dr. Lopez, could you please talk to Lime or Lime, whatever is the name? They keep
One
writing.
second, my dear. One second, my dear, please.
All right, I'm sorry. I'm not gonna do it because I'm at work. I'm not gonna do it. Sorry.
Okay, it's okay. It's okay. I'm not for or against it. That's not. I can't tell someone not to write it, but no problem. Thank you though for understanding. If you guys notice, I'm not very controlling at all, right? You guys can talk about anything you want on your WhatsApp, anywhere. I value people's choices more than anything. I don't delete anything from my Facebook either. If you notice, not like other people, right? Cannot say anything bad about their courses or their way of teaching. I delete nothing. Pure, say whatever you want, whether it's good or bad. I totally respect you, and I can probably learn something from you, right? I know I can learn something from you. So when it comes to DMDD, give me my mood questionnaire. I say this so many times, right? It's not part of here, but it will make sense someday. Even a mood questionnaire I give for my bipolar patient. Why was DMDD created, right? It was because too many of us, like me, giving diagnosis of bipolar to children and adolescents. And that can literally ruin their possibilities to get some better jobs out there. Okay. So first thing is to, when you hear DMDD, you say, give me my mood questionnaire. Okay. Now remember, it is a mood dysregulation, just like bipolar. It is, but presents in a different way. In a sense here, it does not present like what happened to my screen? Is it crazy or is only my side?
We can see you.
Yeah, we can see it.
Oh, you can see it? It's okay?
No,
Okay.
we can't. No, we can't.
No?
It's too-
At
yeah.
the
No, we
All right.
cannot.
So someone is
This
presenting.
one is here, this one is
About
Someone is
hijack
over
your
the
screen,
screen
Dr. Lopez.
Right. So
at the
someone
spot.
hacked my
Yeah.
screen. Okay.
Okay,
So
better.
I trust it was by accident.
It
So
was Trump.
DMDD, give me my mood questionnaire. That is high yield. Okay. Now they present with mood dysregulations. You could, first thing, therapy for children. Doesn't work, then we can try an SSRIs, antipsychotics, mood stabilizer. Okay. We want to screen for family history of bipolar. So think of DMDD as a little bipolar kid. I'm trying to make ways for you guys to remember. Okay. They may not be technically correct, but for the test, it works. Okay. Yes, right. Major depressive disorder, right? So that is the classic symptoms of a major depressive disorder. So maybe some of you guys pressed it too fast. Maybe the question was written poorly or whatever might be the case, right? We have to know those concepts. Folks, the test is hard. The test is hard. If you think, and I'm not trying to make fun of anyone, that I don't care what school you went, well, I want to say that, but if you don't take the time to learn the content, your possibility of not passing is super high. So when you think of a major depressive disorder, it is low mood, tired all the time, don't want to do anything, doesn't have any pleasure in doing anything. Oftentimes they may be losing weight because they don't even feel like eating. They feel worthless no matter what they do, and recurrent thought of death. There was nothing that says, hey, I don't want to, separation anxiety or, one second, folks.
Unless they're not so.
All right. So, and I'm not trying to be harsh or mean by any chance, but I'm trying to warn you. Study, please. Study hard. The key here is initiation of treatment. Okay. So the question is, why would we start an SSRI before anything else, specifically for someone that might overdose? The key is SSRIs in general are less harmful than other medications, right? So by starting on SSRIs, fluoxetine, Lexapro, Prozac, right? This would be a good choice. Good choice, right? So amitriptyline is a TCA. TCAs think of causing possibly cause cardiac arrhythmia, right? In fact, TCAs are actually better in sense of achieving resolution of the problem, but it comes with lots of side effects, right? And bupropion, excellent antidepressant, specifically when you add along with an SSRI or for someone that is very specific. For example, for someone that does not want a sexual side effect, right? Or feel very much tired all the time. Bupropion could be a choice, but they are not the first line medication. Wow. All right. You guys feel the pressure to pick something because everybody was picking super fast there? Yes. So SNRIs like duloxetine, Effexor, they're very good for pain control. Now, what else can be good? TCAs. But in between SNRI, serotonin norepinephrine reuptake inhibitor, right? You would pick that. Okay. Now think of SNRIs for fibromyalgia, right? And when we talk about fibromyalgia in patients, they are at a higher risk for sexual abuse. Would be something that we kind of want to screen for. Okay. Neuropathic pain. Now, if you are prescribing an SNRI, you should be thinking about your blood pressure. No wonder has norepinephrine, right? We'll definitely affect, I mean, in theory and in practice will tiny bit raise your blood pressure, but we should be concerned about that. Okay. Right. So if we think about Wellbutrin, think of a seizures contraindication. Think of eating disorders in general. Okay, contraindications. Now, if we're talking about eating disorders, you really need to know bulimia, anorexia, binging, eating disorders, right? How are they alike and how are they different? When would you possibly start working with CPS for someone with anorexia? How low is the BMI? You know, if we're talking about anorexia, what is refeeding syndrome? How do they present? What are the symptoms of it? Right? Because all these are very important and critical patient. Although I'm very worried about my eating disorder patient, specifically anorexia, for possible suicide attempt, my number one condition that I would be most worried is schizophrenia, above all. I thought I turned off the game by mistake. I didn't. Good. All right. So yeah, that patient that has a plan and intent, right, is way over a safety plan. Please do not make the mistake of safety plan versus safety contract. When in terms of suicidality, please understand that. I'm not saying parents that are beating their child because they're having bad wedding incidents, right? In terms of suicide, safety contract is almost always 100% of the time the wrong answer. Safety planning, it's a very good answer, right? You got to know what are the difference, right? Well, we got new people over here on the podium.
Okay, going now, Nicholas. Yes, I am. Of course, I'm on my.
All right, good choice. So why not B, right? So I'm super sorry about the misspell there.
It's the
Super sorry.
first. It's the
Uh,
first line medication online, the lithium.
so the patient present with bipolar depression, right?
Yeah.
So present with bipolar depression. So what yesterday we went over and I said, hey, you guys need to. It's not showing. You guys, can you see the screen or no?
Yes, we can.
Okay. Okay.
Yeah,
So yesterday we said, hey, bipolar, there are some, then we went over the medications and they said there are some medications that you need to know. I specifically highlighted uh, Latuda for bipolar depression. Okay. So that is one medication you need to know, right? I went line by line, lamotrigine, some others, Latuda. I even said the Latuda you need to give with food. And so is Geodon, kind of relating towards the food. Okay.
Weight loss.
All right. So I'm so happy to see that most of you guys actually pay attention on the TSH level yesterday. This is actually a hard question, harder than most questions, right? So you need to know TSH levels by the details if you want to get questions on hypo and
Thanks,
hyperthyroidism.
girl.
And guess what?
0.5 to
If you
5
don't, if you don't know it and rushing to take the test, it's another point that you are going to leave it behind. Okay, so please understand the thyroid levels in details. Okay, and so is the dopamine pathway. They are not just going to give you a simple question, they might give you an answer with two phrases connected, right? Where partial incorrect with the second sentence being correct. So you have to really pay attention. Okay. Okay, hypothyroidism, everything is low and cold, and they appear like depressed. Hyperthyroidism, everything is hot and fast, and they appear like anxiety and mania.
No, no, it's okay. Папочка, не надо. Девочка, don't
Your
worry.
your mic is on, my dear.
Okay.
All right, next question. Okay, so hopefully most of you guys picked up on the cue. It's had there 6 months. And I even emphasized this today. So I was hoping for 100%. We are not there yet. But remember, generalized anxiety disorder, the question should say 6 months. If they don't, in this case, during COVID time, during 2 years ago or something, I don't know, right? That would be assumed 6 months. Okay, 6 months, it says here in the question, for at least 6 months. That is high yield for you to get another question and get a little bit closer to the 105 that you need out of the 150 in terms of the ANCC PMHNP board certification. So that is panic disorder, okay? So versus panic attack. All right, so you need to know the difference between panic disorder versus a panic attack, right? So if it's a panic attack, it's usually one big attack, this immense emotions and physical and psychological symptoms, heart rate, impending doom, right? Now, with that, why do we need to know? Because we are going to treat them differently, right? For the board, things like hydroxyzine, right? For example, Atarax would be a good choice. Well, why not benzos? Well, technically, benzos would be the correct option. But for the board, try something that is less addictive first. That doesn't work, then we can consider benzos later, right? Now, when it comes to be a panic attack, our treatment is going to be totally different. Panic attack is a conjunction or more than one panic disorder, is more than one panic attack. So many panic attacks. In that case, we are going to use SSRIs. Okay, so that is one of the reasons why you need to know the difference, because the treatment will be different.
C is spelled wrong too, Dr. Lopez.
Yeah, yeah. That, like it's eating me inside here because I didn't have time today. I came in just half an hour before the game to make correction. But yes, panic disorders, right, versus panic attack is high yield. We need to know that in detail. Otherwise, we are going to make mistakes that we should not have made. And I just talked about this one slide before we presented the question, right? I promise you that I do not know those slides. It's just thoughts that come through my head. And I'm like, wow, this is important to talk about because I haven't seen this Kahoot in 4 months, actually. I couldn't get to it. I was like, okay, this is going to be the game for today. And I didn't have time to make the corrections. But these are important topics. And by chance, they're coming up just before we talked about it. So what does it mean to you guys? If I'm going out of the way to mention something and you don't understand it, write it down. Maybe we're not able to answer the question right now, but we can talk about later and explain it. And if you still don't know, we can find a different way to explain it. But everything that is said while during our live classes or Kahoot, there is a meaning, a purpose behind. It's not because I love to stay with you until midnight, which I probably do, but that's not the main reason, okay? So today I'm covering for a psychiatrist, right? And someone asked for a refill of medication. So I went over that. I gave her Adderall. I gave her Effexor, and then of she was out of Xanax, and I said I'm not going to do Xanax, right? And the reason why I don't like to do Xanax is I'm covering for someone which I absolutely amazing psychiatrist, amazing, right? I learn from her all day long, no problems. But without me assessing, it's crossing my comfort level, right? So I told the patient I might do that. I might break my own rules and give you, since I trust this other person. There is a reason why you have it. But Xanax, benzos, specifically Xanax, are very addictive, right? Very addictive. As some studies may say and suggest that benzodiazepines, depending on what kind and how long they are on it, it may be more difficult to take them out than cocaine. Whether I believe it or not, I'm not that for debate, right? Because I don't really know, but I go by what the research says. So it's very addictive. So be careful. Consider your patients if you are going to prescribe those medications very well. All right, close, close, close. So I'm super happy to see that. Be on a watch out for maybe a question related to that, whether it's malingering, whether it's factitious disorder. Conversion disorder is real. They're not doing that on purpose. It's happening. Factitious is fake. Malingering, they have an intent to earn something, whether it's money, time off work, right? And be careful because sometimes they might say adjustment disorder, and then you need to know, you got to look what are the stressors followed by the symptoms, what kind of a symptoms it is, right? So they'll be presented in different way. When it comes to conversion disorder, it's classic that they will say there was a stressor followed by neurological symptoms followed by clear by the medical team. Perfect. That way we know what conversion disorder is, and I don't care what kind of questions they will send you on your way. You will know. So it's very helpful that we start learning the construct of each of the questions. Okay. So today, who we have here in the podium? All right. Good job. All right. And first place is drums. Nurse MP, she called it. So good job, everyone. Let's see. Lithium, PMHNP. You guys are the team today. Napal, Claudia. Good job, everyone. But folks, like I said, it's extremely hard, right? So they made it the podium today. Let's see. I'm gonna take a picture, see if they can make the podium next week. Next week, y'all should fight for the podium and say, nah, next week you guys gonna be out of the podium. So that's how it's gonna play out, okay? What we're going to do real quick in 10 minutes, maybe not 10 minutes, maybe 15 minutes. Let's do a review of yesterday's content. Super fast. It's not for teaching, but simply to reabsorb what we learned yesterday. Lightning fast, okay? And then we're gonna open up the floor for questions. Before we do that, there is a mistake on our calendar. And I believe next week it should say only Tuesday. There is Tuesdays, Wednesdays as well. We're covering module 4. So module 4 is the weakest. Most people say that is my weakest. And I'm not too concerned if they say that. Only 17 questions per ANCC blueprint. Sure, we want those 17 questions. But if you're telling me this is your weakest, you are also telling me you are very good or good at 1, 2, and 3, right? Then in that case, something has to give, right? So let's go ahead and do this real quick, lightning fast. It won't be a lecture. It won't be like yesterday's classes or so forth, right? Just so what I want to get out of this is simple, right? Learn to review the content, because if you don't, you are going to forget what you learned. As simple as that. So if you've been through module 1, has been 4 weeks, guess what? You're not going to remember. But if you keep the habit of, let me shut this music off. If you keep up with the habit of always rehashing, going back to what you learned, it becomes part of who you are. There is no difference. It becomes part of your new identity, your new job that you'll be performing the next week or next month or so forth for the rest of your life, hopefully, right? So this is part of our diagnosis and treatment. So there's our module 3. We talked about tolerance is needing more of the same substance. Now we need to know withdrawal, dependence, abuse, and addiction. Addiction is doing anything possible despite the consequence to get what they need. It's compulsive drug seeking. We talked about low potency, high potency. Haldol, need a little bit of those. Low potency, you need higher milligram to achieve the same result. Okay, then we answer questions. We talked about kindling, lowering the seizure threshold. We would be concerned with alcohol withdrawal, Wellbutrin. We talked about the 3 types of ADHD, inattention, dorsolateral, impulsivity, orbital, frontal, right? That's responsible for that. And the combination of inattention, hyperactivity, and impulsivity. Okay, and then we went on to talk about each one of those. Where is ADHD comes from? This can be broken down even further, as we mentioned. The frontal cortex, basal ganglia, reticular activating system. Don't forget about your arousal and waking transition. Neurotransmitters for ADHD, the same ones for major depressive disorders, ADHD, and Tourette's, DNS, dopamine, norepinephrine, and serotonin. ADHD, started on a medication, 3 years and over, amphetamine, develop tics. Don't care how good the medication is. You stop the medication. All right. What kind of behavior therapy? We can do behavior therapies. We can do patient and parents cognitive behavior training. So, which was part of one of the answers today, right? We said know your scales, Vanderbilt, Connors, parents and teaching rating scales. We went on to talk about stimulant abuse, knowing the signs and symptoms of stimulant abuse. Do not confuse stimulant abuse versus side effect. The question, if it's leading towards stimulant abuse, they might give you an adolescent that asking for more, blood pressure, heart rate is always up no matter what, and may say, it doesn't work, I'll need more. We went in detail on all the clusters, A, B, and C. We kind of broke down each one of those. And we said, hey, for my borderline, please remember Marshall and Lyham. What is the treatment for borderline personality disorder? Think of a DBT. Why? To decrease self-harming behaviors. What a borderline looks like? All of these. All right. Narcissistic, they don't care. They'll take your money. Doesn't care if it's an old lady. Has no remorse. Do things that are completely illegal as long as they get what they want. No empathy. Narcissistic, the best thing ever since sliced bread. This feeling of importance, right? They want the admiration, but they do not want to do the work. All right, spectrum, autism spectrum disorder. So it's exactly that. It's a spectrum all the way from the left to the right, right? Deficit in social communications and interactions in multiple settings, just like ADHD, multiple settings, right? They have a lack of a social reciprocity. They can be nonverbal, right? And they like to do things in the same order, kind of stuck on the same thing all over. When we have a patient with the autism, we want to screen for all these conditions, specifically ADHD, depression, anxiety, and so forth. Think of males. Think of a possibility of intellectual disability and family history. These are risk factors. Mom and dad says, my baby wasn't cooing by age 1, not responding when called by their name, no eye contact, not looking when called by their name, loves to line up toys in a certain ways, and lack of imaginary friend. And we also said they have a lack of imaginary friend, but they have something extra. Parallel play, prolonged. Okay? Then we say, okay, we can use some tools to kind of screen. You need to know the name because they will not give you the whole name. What they will say is MCHAT, A.Gs, ASQ. Then how am I going to know if I didn't study for it, right? If they become super aggressive, we can call risperidone. Is that the only medication? Absolutely not. Abilify could be the possible answer. Thales Lopes risperidone for some reason. Okay. Then we went on to talk about Raritan syndrome. She's a girl with decreased or deceleration of the head with stereotypic movements. Why is a girl? Because it's most likely to be affected by primarily girls. Just like autism, more of a boys than girls, not as much as Fragile X, right? Remember the description of Fragile X that we went over yesterday? I'm not going to say it here, but DMDD is a mood dysregulation. Give me my mood questionnaires. Okay? 6 to 17. And this is exactly what they look like. We need to know the difference between DMDD versus ID. ID is more of an explosive of unwanted anger, while DMDD is tension and mood swings, outburst. Okay, and then we compared them. What do they look like? Then we said ODD. Somebody said this in a chat. They do not like order and control and someone of authority. That will help you to differentiate between ODD, right, versus conduct disorder. Conduct disorder is your little antisocial, right? Why do I say little? Remember, personality disorders, most, at least for the test, we're going to say they have to be older than 18. Because if they present a question, say, kills animal, violate the rights of others, aggression towards the animal, and he's 19, we are not going to pick conduct disorder. We're going to pick antisocial personality disorder. The same scenario, the kid is 12, conduct disorder it is. So knowing those difference will help you so much to get the right answer. Remember, whether it's conduct disorder or antisocial, no remorse is high yield and animal cruelty. In fact, in order to be antisocial personality disorder, they must have been, according to the DSM-5, conduct disorder. Doesn't mean that they needed to be diagnosed, but they may need to present those symptoms during adolescence. Just like an ADHD person, when we say, if we look at the DSM-5, it does not say that you need to be diagnosed. You just needed to present those symptoms before the age of 12. Then we went over and said Fragile X. I'm not going to say all the things, but he's a small guy with elongated head, hyperextensible joint, abnormally large chest, and he's short, right? With intellectual disability. Now, Rediton, girls, Fragile X, boy, autism, boys. This will help you, I promise you. Okay? Major depressive disorder. I was blown away when we got that question wrong, right? These are the classics: sleep difficulties, guilt, energy, concentration, appetite, decrease, right? Moving slowly, and suicidal thoughts. Again, what are my neurotransmitters? GNS. Okay? And how do they present? I don't know. They don't try to answer the question. They don't put the effort into. And why is that important? Because questions of an adult, older adult, may be similar to dementia. And how are you going to differentiate them? I don't know. It's high yield. Okay? Now, how do we manage major depressive disorder? Well, starting with an SSRIs is always the first line of treatment we talked about because of overdose. They are safer than other options, specifically TSAs. We went on to talk about the neurotransmitters on each one of these classes. SSRI, serotonin, MAOI got all three of them. TCAs has serotonin and norepinephrine, but not dopamine. We talked about how do we manage major depressive disorder. They're resistant, super resistant. After we tried everything, electroconvulsive therapy, we can also try TMS, right? If we try a few drugs, then we go TMS, and eventually electroconvulsive therapy. I have never in my entire life sent a major depressive disorder for electroconvulsive therapy. So that is how rare would that be? You would be judged, looked at it very closely if you do. Not saying that you can't, but you got to have a good reason. Oh, what are the hallmarks of electroconvulsive therapy, right? They cannot have cardiac disease, compromised lungs, they need anesthesia, they cannot have inability to tolerate the anesthesia. What if they have a brain tumor or a brain injury? Probably not a good idea, right? Cardiac dysrhythmia? No. Now think of it as the short-term memory, as the high yield and confusion after they just been through a controlled seizure. That is what this is, right? This is a controlled seizure. All right, then how do we manage suicidality? We always think of it as super serious. We have to know our risk factors for suicidality. If we are comparing patient A, B, C, and D, you guys remember, you were in the class, I'm not going to give it out at this time, right? We need to count each of those risk factors. Bipolar disorder, right? What is it? Dig fast. What are the dopamines involved in bipolar disorder? Well, it's same thing as norepinephrine, serotonin, and dopamine plus GG, GABA, and glutamate. Okay. If we talked about bipolar disorder, lithium is the gold standard. Do we start lithium first? Probably not, right? Unless if you want to keep your patient for a few weeks and wait for the lithium level to come down, not going to work, right? But it is the first line treatment, right? Often used for mania, prophylaxis, and antidepressant augmentation for those with high risk for suicidality. We need to differentiate suicidality with mania or bipolar, I'm sorry, lithium. Suicidality, schizophrenia, clozaril. These are the only two medications that have been shown to decrease the risk of suicidality for these specific populations. Oh, remember what we talked about on the question. Specifically, I highlighted this. You need to know those medications. Lurazidone, FDA approved for bipolar depression. Lamotrigine, the least weight gaining mood stabilizer. Don't confuse with antipsychotics. If your patient is pregnant on lithium, on Depakote, on carbamazepine, stop the medication, transition to lithium. Also, we can use olanzapine and fluoxetine. This is a specifically combined medication. You're not going to give one in each and say, hey, I don't have the true medication, but I will just go ahead and open them up and make a cocktail for you. No, right? This is also for bipolar depression. Okay, Depakote, very good for acute mania. You could, in theory, and a lot of people actually do in practice, if you don't want to give an antipsychotic, your other choice could be Depakote. And then we went on and answered some questions. What is the difference between bipolar 1 and 2? Right? We went on very details. What is the normal TSH value? How do we identify hyperthyroidism, hypothyroidism, right? What do they look like? That's what they look like. And how the questions, one thing is understanding, another thing is answering the question. If you look at this question here, right? It is asking, which of the following labs results in a 50 years old is most indicative of hypothyroidism? Okay, so if you know you're looking for hypothyroidism, you start with your TSH. Is it going to be more than 5 or less than 0.5? Right? Is it going to be high or is it going to be low? And then look at each answer choice and start eliminating what doesn't fit. Now you have less work to do. So we went into a strategy learning the content first, and then strategy. Now, if we don't know the content, then we can fall back in the strategy, right? But these are all good things to bring in your toolbox when it comes times to go on for the task. When you went on to say liver function task, AST, ALT, we did a little bit of math, what this means. And more specifically, we went on to say, hey, when the liver is affected specifically by alcohol, these would be elevated and they are high yield for you to remember. Okay, this is kind of easy. You say your electrolytes plus BUN if it's an acute, right? Not entirely all the electrolytes, but H&H, platelets, and albumin as well. What is a serious liver condition and what kind of medication we would use as far as alcohol withdrawal with any of these liver conditions or elevated labs? Conversion disorder, can't convert. You guys got it. Most of you guys got it correct today. And we talked about patient reports unexplainable symptoms such as neurological symptoms such as blindness, paresthesias, paralysis, mutism, motor symptoms, right? And then it's usually after those symptoms happen after a stressful event. Then we went on to look at adjustment disorder very in detail. These are the type of adjustment disorder that we cover. We went on to talk about PTSD versus acute stress disorder and versus when not to pick acute stress disorder super high yield. Right? I even highlight these things for you guys on the PDF. Maybe it helps someone. We talked about management, pharmacological management. Prazosin would be great for nightmare. Talked about the phases of EMDR. Remember BID. Remember what do they look like and what is our action during that phase. Okay? And we went on to talk about obsessive compulsive disorder. I think I did not a good job. I did not do a good job yesterday. Some people were saying, according to the feedback, some people were saying, how do I know when it's PONDAS and how is OCD? Well, OCD is the diagnosis, and what brought the OCD to the party is the PONDAS, right? So usually as a kid that never had OCD, spent few days in the hospital due to a streptococcal infection. Now he presents with OCD, right? So then the question can only be one: what may have caused the OCD, or what situation would better explain this, this scenario? PONDAS, right? Sudden onset of OCD in children could indicate pediatric autoimmune neuropsychiatric conditions associated with streptococcal, right? High yields. I even highlight in red, Think of this. Is a link between OCD and streptococcal PONDAS. All right, then we will know how to treat types of OCDs a little bit, right? We went on to say tic disorders and Tourette. We need to know this, guys. If you don't know this, you might be leaving 5 questions or more on the table, right? Tourette, 2 modems, 1 vocal, over 1 year, and has to happen before 18 years of age, right? Otherwise, it's not Tourette's. What are we going to do? Clonidine, guanfacine helps with impulse control. Well, I'm looking at the question. It doesn't have in there. Well, haloperidol, Abilify, Famotidine would be also great choices, okay? Then we went on to talk about provisional tic, modem tic, vocal tic. What is the difference? And lastly, schizophrenia, right? We said, hey, if we put someone in an MRI, what we would see, enlarged ventricle, what are the dopamines involved? Makes sense. We know dopamine is high We know glutamate is high. So what would be low then? GABA and serotonin. Very important we understand the age of onset, right? And why schizophrenia comes about, right? About inadequate synapse formation, excessive pruning of the synapse, excitotoxic death of the neuron, intrauterine insult, such as malnutrition, oxygen deprivation, and so forth. What are the positive symptoms of schizophrenia? Where do they happen, right? Then we talked about the A's of fat, flat alogia, poverty of speech, ovulation, lack of motivation, apathy, abstract thinking, the hallmark, the lack of abstract thinking, the hallmark of schizophrenia, anhedonia, attention deficit. Great. So all my A's falls under the negative symptom. That saves me some brain power to remember negative symptoms because of a decreased depletion blockade of dopamine, where mesocortical pathway. Then we talked about how is the first generation versus second generation, what happened there, how does it come about in the different pathways. All right. And we talked about, hey, these are the characteristics of schizophrenia. What can we use? Which one's least sedating? High yield ACT, assertive community therapy, and the why to keep patients in a community, not in a hospital. We talked about metabolic syndrome. What is it? What is the first physical sign of metabolic syndrome? And then we call the night. So just like I went on today, maybe not looking at the script, that's what you should do for each module before you advance to the next module. For example, here is schizophrenia. So before you even go down, you say, all right, what are the things that I remember about schizophrenia? And then you say, okay, yeah, I remember MRI. What do I see? I remember the age. What are the ages? What is the etiology of schizophrenia? Okay, what are the medications for schizophrenia? What else did he say? Yeah, he talked about the positive symptom. Where does it happen? Where's the negative symptom? How does it happen? What kind of medications can we use? Right? And we went on, and then you try to say it. If you are able to verbalize it, and you don't have to be perfect. If you are able to verbalize it, now you can go back and look at it, because this builds confidence. If you can speak without looking, you know it. There is no other possibility, right? But reading, it's somewhat of a little bit of a passive. But when you're speaking to yourself, comes out, you know the content. There is no doubt, right? Now, then you practice. You finish module 3, you have to practice module 3 question bank. Otherwise, you are going to forget what you learned, okay? So, guys, it takes work. There is no doubt about this. But make no mistake, the pain of regret is so far above and bigger than the pain of doing something that you do not want to do. The key to success to anything is don't let your mood determine what you do. I don't want to go work out. I'm going to work out anyways, whether I want it or not. It's not a choice. It's not negotiable, right? So if I let my mood determine what to do, then I might not do a lot of things, right? So when you establish your schedule, be determined to close the door, shut the phone, and be just you and the books and the content. And be curious. Don't understand. Email me. Contact me by email, please, not by phone, because otherwise I can't answer the emails. This is the most important test of your life. And this week we had a plotter of people that passed. And we had few that did not. I lose the sleep. I honestly do. Even though we had tons of people that passed, because I wonder what went on and how could I have made this a little better. Uh, and there is no right or wrong answer, right? Whatever is going on with you, whatever it is in your life, you have to give priority always to your family. That is not a negotiable either, right? So take a little bit longer. If you're not feeling confident yet, don't test it, right? As you're going to the diagnostic test, it is a test. That's when you should be like, this is my board. I'm not taking a test. I'm taking my board. And then now you have 4 opportunities to ace it. And between jumping from one board, which is our diagnostic test, to the next, you need to be aiming higher, higher, and higher, right? And that takes planning. Lack of planning will bite you in the ears. All right. So with that being said, this is not a kind of like, you know, everyone learns different. And we have had people that failed the board 5 times, right? And they came, they did something different in our course and passed. I don't even claim that was because of our content. I think they switched the things that didn't work for them. And we all make mistakes. I've been in the dump before. I failed tests before. I failed my GRE. I mean, it was technically not failing, but I did not get the score that I needed to be where I needed to be. I went on 6 months without eating and pretty much starting until 2 o'clock in the morning, plus working 12 hours every single day because I was obsessed with getting my goals achieved because I had a very good opportunity and I needed a nearly perfect score. And I felt very much short by miles the first time. But guess what? The next time I got it. It cost me, unfortunately, a vacation to Disney in Florida with my family because it was in the last 2 weeks and I know that I could not stand myself if I was at Disney having a good time and knowing that as soon as I come back, I would be taking the test. I said, you know, honey, my sincere apologies, but you do not want to be next to me in the next 2 weeks because I will be cranky and not a very pleasant person. So please go and enjoy, do whatever, buy whatever you want. We'll take care of that when you come back. Enjoy your time. Let me stay alone because that was important to me, right? And she said, you know what? I hate you. Got it? But that's what you need to do. That's what you need to do. And that's what I did. And that was what I needed to do to feel good about myself because this was so important. It would have changed my life, would have changed our family's life. So I had to do this. I gave up a 2 weeks vacation, you know, but I don't feel sorry. It really paid out thousands of times. So, you know, and everyone have a different level of comfort. What are you willing to give up to achieve your goals? Now, put in perspective, all of you guys are capable. And I don't know all of you guys in details, right? But let's say something that's 100% true. You finish your BSN, you know that it's not an easy degree. You worked at least few years, most of us 10 years. Then you went back to a master's degree or a doctor's degree and you pass. Guess what? You are more than capable. I have no doubts. And the failure today does not anywhere come close to define who you are. Okay? Take a break, go for a run, put it all out, cry as much as you want to, and come back so strong and unstoppable. Come back with anger and as all the emotions that you have and put into achieving your next goal. All right. So that being said, let's go ahead and answer any possible questions that you may have for today's event. So let me just stop this real quick here, if we are recording. I'm not sure if we are, but let me just stop this now. Quick question, folks. Stop.